Thank you very much. You did that so nicely. Would you like to just do the rest of my presentation for me, please? So good morning, everyone, and thank you for coming to this. Research is not to everyone's taste, and particularly on a Sunday morning after a wonderful party, so thank you for coming. So I'm going to talk about this study where we tried to introduce self-administered moxa into an NHS oncology setting. It is very researchy, but I have a few anecdotes along the way to lighten the mood. So I just want to begin with the many acknowledgements. The British Acupuncture Council, for their grant of £10,000, which funded this study, and the research, the support of oncology research team at the Linda Jackson Macmillan Centre, which is where I work, Mount Vernon Cancer Centre, particularly the chemotherapy health professionals, the oncology health professionals, and we're part of East and North Hearts NHS Trust. The research team, I would also like to introduce myself as a principal investigator, Claire Scarlett, who you see pictured here. Claire was our health improvement practitioner, and she was really the driving force behind this. So she recruited all the patients, she identified who was eligible, she taught all the patients the routine, she followed up, she collected the data. She really is the well, it wouldn't have happened without her, so she's fantastic. Teresa Young, who manages the research team. Dr. Rob Glynn-Jones, who is an oncologist for colorectal cancer. He's a wonderful man. I have the privilege of doing a lot of work with him. He is very pro-acupuncture, and but when I suggested that he might like to become involved in our moxa study, he said, moxa's a bit far north, isn't it? But still, he signed his name to the documents, and he gave us patients, and so that was very helpful. And Friedrich Stabler, and I'm just going to talk about Friedrich. Does everyone know Friedrich? Okay. Friedrich here on the left, he wrote the papers that inspired and gave presentations at the British Acupuncture conferences that really inspired me to initiate this study. And Nini, so he wrote the kind of seminal papers in the UK reporting his findings, 20 years of clinical experience. Nini Davis, she wrote a case study of using stomach 36 for a patient with cancer. And so these were kind of very inspirational pieces of work for me. I myself, I have to declare my interest in moxa. I am a prodigious user of moxa in many forms, okay? I use it very much in my clinic, so some days I practice from my home, and some days my partner comes home and he just can't stand the smell of smoke in the house. So I have to rein myself in sometimes. And I have worked to use it on my patients and myself, and tried to introduce it in various formats into the NHS, which is an interesting project. So, just a little bit of the history. I thought I'd just kind of do an overview. So back in 2014, remember then, pre-Brexit, the world was a very different place. I woke up one day and had a great idea. The British Acupuncture Council research grants had been announced, and I thought this might be an opportunity to explore this idea of using moxa to improve outcomes for chemotherapy patients. And so we put in an application I spoke to Teresa, my boss, and she said, yeah, go for it. She's very supportive that way. She supports innovative research. And so we put in the funding application in April, and in July we found out that we had a grant of £10,000. And it took a little while, and I can't remember why, but I think there's a lot of formalities to go through. December in 2014, we actually signed the contracts and could move ahead. And it looks like a big gap between December and August of the next year, but a lot of work was going on. So we were writing a protocol. There's a lot of informal research. There's a lot of paperwork and bureaucracy to go through. So we were going through the hoops, and obviously every time you fill in one of these forms, there are queries coming back. So we were dealing with that. I'd just like to say that right when I wrote the funding grant, it was kind of easy for the British Acupuncture Council because the BACC innately understands moxibustion and what it is, and it also innately understands stomach 36, so I didn't have to do too much explaining. But once I got the grant, I thought, oh my gosh, I've got this money, but how am I going to convince the medical professionals here that this is a thing that they should take on? Because, you know, mox is kind of a wacky idea, isn't it? Even I, as much as I use it, sometimes I just think, this is weird, yeah? Okay, just don't edit that, won't you? So what is a health professional going to think of this? So anyway, but we kind of did a little informal roadshow, and I took moxa sticks round, and just anyone who was involved in chemotherapy, I would walk into their office and I'd have my moxa stick and I'd say, I've got some funding. You know, have you got a minute? Because I've got some funding to do some research on a novel intervention, and they would be interested, yeah, because one, I had some money. I wasn't tapping them up for money. And two, they are interested in solutions to some of the insoluble problems that they have. And some of this was so successful that one of the oncologists became involved in helping us to write our protocol. So that was good. So by October 2015, we had ethics approval, and I would just like to say ethics approval is a very scary process where you are encouraged to go to a meeting with possibly 20 healthcare professionals from various backgrounds, and they will quiz you on your research. So we went to that meeting. You're always kind of apprehensive. You're sat outside of a hall waiting your turn. It's like an audition. And the previous applicant came out of the room, and you could hear there was, some discussion going on about that. And then the laughter started, and we thought, they've started on the moxa study. But we went into that meeting, and they didn't ask us a single question about moxa. So they had no concerns about moxa or what it was or the safety of it. So I attributed that to my excellent skill in writing protocols and ethics applications. They were more concerned with our recruitment policies. So that was interesting. So there were more approvals to get locally within the trust, and so by the beginning of February, at the end of February, we were able to start recruiting patients. Okay, so you just see what kind of preparation is involved for these studies and how much time it can take. Now, part of that is because I'm part-time, but a lot of it is the elapsed time for the authorities to do their magic. Yeah. In the spring of 2016, we also published our protocol. It's a good idea in research to publish a protocol, and this is published in eJOM. I thought I had my copy here. Anyway, it's gone wandering. And there's a few copies up there. In fact, there are enough handouts to go around. I thought there wouldn't be, but everyone can have one. So I've laid out a load of stuff here. Some of it is examples of the, oh, right, okay, thank you. Thank you. Yeah, it was published in eJOM in 2016, volume 8, number 3. And there are a few copies of it there. So there's anything that's in the plastic wallets, please don't take, but there are some copies of the protocol and some handouts of a poster that you see there, so please help yourself. So that's a kind of background to things, and I forgot to set my timer here, which I do to keep track of what I'm doing. So we have an impressive list of approvals, okay? I've talked to you about the no concerns expressed about the moxa staphy in the ethics. So these are what we gleaned from all our work. So the intervention here is teaching chemotherapy patients in an NHS setting to use daily self-administered moxibustion to Suzanne Lee's stomach 36, and we're aiming to reduce chemotherapy-induced pancytopenia, and I'll explain what that is in a moment. This is in an NHS setting, and so it's outside of usual acupuncture practice. We are plucking this out of normal practice, okay? So these are people who are not necessarily seeing an acupuncturist. We're not offering an acupuncture service. So they've probably never heard of moxibustion, even if they've heard of acupuncture. So we're kind of, introducing them to moxa cold, if you like, yeah? So, and we can debate whether that is the right thing to do, if we should take it out of practice, but I think it's an interesting concept, and if moxa is that good, then it should be available to everyone. And I'm kind of, my future vision is this idea of moxa parties or moxa cafes, which I understand happens in Korea a lot, where people meet and they do moxa together. I love that idea. So, and why? Well, everyone in this room, with the possible exception of our CEO, knows that moxa on acupuncture, we know this from very early in our training. This is one of the workhorse points in the Chinese canon of acupuncture points. It is the most important point to generate qi and blood. It tonifies qi of the whole body. It pursues to preserve and maintain health. It prevents illness. And the classics talk about it. All diseases can be treated using moxa on stomach 36. So what's not to like about that, yeah? So what is the medical problem that we're addressing? Well, chemotherapy agents reduce bone marrow activity, so they affect the production of blood cells. And you can get, the umbrella term here is called chemotherapy-induced pancytopenia, or CIP. And it can take many forms. So if it affects the white blood cells, you get a condition called leukopenia or neutropenia. If it affects the red blood cells, as we probably all know, you'll get anemia. And if it affects the platelets, then you get thrombocytopenia. And so all of these have a potential impact on chemotherapy schedules, okay? So if these counts go too low, the oncologist might have to reduce the dose of chemotherapy, or they might have to delay administering chemo for a week or two until the blood counts come back up. And whatever we think of chemotherapy, if you're going to have it, you want it to work optimally, so you want it on time and at the right dose. So this has an effect on survival, especially for curative and radical chemotherapies, because if you don't get the right dose at the right time, then it affects your outcomes. And all of these conditions have an effect on patient experience, and they reduce their quality of life, and they add to the cost of cancer treatment. So let's look at each one in turn. Neutropenia, sometimes called leukopenia, there are four grades of it, but the two that are the most dangerous, or that we're most worried about, are severe neutropenia and febrile neutropenia, which obviously comes with a high fever. And these are potentially life-threatening. There's a risk of serious infection, blood sepsis, and so death is a possibility. And when chemotherapy patients are briefed on having chemotherapy, they are told they learn to recognize the symptoms of neutropenia, because if they have these symptoms, they must act quickly. And they get a little card. They go to A&E, and they show their card, and they will go to the head of the line in A&E. So this is a really dangerous condition. It has the most serious effect on chemo schedules and on survival, and it's kind of hard to say who is going to get it and when, but they reckon that about 20% of patients who have chemotherapy will experience severe or febrile neutropenia after the first cycle of chemo, and that can rise to 30% during cycles 1 to 4. Okay, so it's serious enough to be concerned about. And the cost of the NHS is estimated at between £2,000 and £3,500, and that can be more if they go into a high dependency unit for sepsis. So what does the medical world do about neutropenia? Well, they have a nice little substance called granulocytic colony stimulating factor, okay? So that stimulates the growth of the white blood cells. And they use this, but it's not used routinely. So it's used as primary prophylaxis prophylaxis on chemo regimes where they know that the risk of febrile neutropenia is greater than 20%, and if it's from 10 to 20%, then it will become secondary prophylaxis. It's not used for all chemo regimens or cancer types or stages of cancer, and there is a cost attached to it, which most trusts would like to avoid. It's also done by, it's administered by self-administered injection, and there are a number of side effects associated with it. So moving on to chemotherapy-induced anemia, there's a very high incidence depending on the cancer type and associated with certain types of chemotherapy, the platinum-based chemotherapies, and it's becoming common with some of the new cytotoxics agents as well. And it occurs in about 20% of chemotherapy patients in cycle 1, and it rises to almost 50% by cycle 5. So this is another big problem. It's treated with blood transfusion, which of course you probably want to avoid if you can. There are something called erythropoietic stimulating agents that can be given. Again, they have a cost and side effects, and iron supplementation and monitoring. So you've got associated side effects and cost implications. And then thirdly, we look at thrombocytopenia. This is a little bit less of a concern unless it's accompanied by very heavy bleeding. And this causes bruising, as you can just about see on this picture here. Nosebleeds, bleeding gums, heavy periods. It usually goes untreated, but if it becomes severe, then there are platelet transfusions. So, given the severity of some of these things, how can moxa help? Well, as I've said before, it's used in classic and modern practice of Chinese medicine to stimulate the immune system and nourish blood. And so we think it may have potential to work with these three aspects of chemotherapy-induced pancytopenia. There's also in the literature some papers that suggest that it might reduce some of the other side effects of chemotherapy, like nausea and vomiting, fatigue, and peripheral neuropathy. And so there's a developing evidence base in the literature, and we're just going to have a little walkthrough of that. So we start off with the lab studies. Mostly these are done in the Far East. And they're done on animals, and so there are papers that report improved immune cell function, and that's with moxa, maybe with moxa on the animal equivalent of stomach 36 there. What is important here is a systematic review of clinical studies that were carried out in China, and that systematic review reports that these studies showed that there's a higher white blood cell count and platelet counts than in the control groups that were used in the study, and also that using moxa reduced side effects and improved quality of life. And this systematic review concluded that there's a low level of evidence demonstrating superiority of moxa over controls in the management of chemotherapy-induced pancytopenia. Now that sounds a little bit grudging, it kind of is, until you realize that one of the co-authors on this paper is our good friend Edzard Ernst, and usually papers that his name is on just say there is no evidence for things. So this is really promising, yeah? Let me open up the champagne here. So, there are some randomized control trials, which you may know are the gold standard for research. One in the USA, where they didn't actually use moxa, but they used acupuncture plus heat in ovarian cancer, and they reported positive outcomes for their intervention. And then in Portugal with colorectal cancer, where they used acupuncture and moxibustion. And what they found was that the white blood cell counts were higher, so were the absolute neutrophil counts, B cells, NK cells, and there was reduced anxiety and depression in the acumoxa group compared with no intervention. So that is promising again. These are small studies, of course. So, on to the clinical reports and the case studies, which were my inspiration. So, Friedrich Stabler, he did his evaluation of 20 years of clinical experience. That's published in the Journal of Chinese Medicine. And Cornelia Davis, more recently, with her case study of self-administered moxa on stomach 36. And that's published in eJOM quite recently. Now, Stabler's protocol, he uses cigar moxa, 5 minutes on each point on bilateral bladder 17, bladder 18, and bladder 20, so the magnificent 6. So that protocol takes 30 minutes in total. He recommends commencing that 7 to 10 days before starting chemo, continuing daily throughout, daily, I repeat, daily. For anyone who ever does a daily practice, you know how challenging that is. Throughout the full chemo schedule, and then for 3 weeks after chemotherapy ends. And so what you need for this is you need a carer, you need someone, you can't self-moxa your back shoe points, and it requires that the acupuncturist make a template so that the carer can find the points. Now, this is a very effective protocol, but it has some practical issues. So, moving on to our study, we've looked at the background here. So what were we trying to do? Well, fundamentally, what's on this slide is just fancy language for saying we're trying to see if we could teach NHS patients to do this themselves, and then to see if they could actually use moxa safely, and if they could carry this on throughout the whole throughout the whole course of chemotherapy. So, just breaking this down, we were going to measure how concordant they were with the daily moxa protocol for the duration of the chemo schedule, and we were going to ask them to keep diaries for that. We wanted to monitor adverse events, so the safety of this. This is a great shortcoming in the literature about moxa. People don't report adverse events, so we wanted to be up there reporting how safe this was. So we were collecting patient report of burns. We wanted to know if this was an intervention that was acceptable for patients. If we offer it, is it something that you want to do? And we wanted to know if the oncology healthcare professionals would find it acceptable. Can you advise your patients to do this? Do you think this is a helpful thing? We had a number of secondary aims, because obviously we want eventually to get to a stage where we can monitor the blood counts and see if people are using moxa, but that wasn't a key part of this study. Here we wanted to see if we could collect the data for this, and then just to analyze it to see what it told us, okay? So we wanted to really collect the data on blood counts for reducing, to see if the people using moxa might have reduced incidence of CIP. And you can't actually, from what we've done, because it's a single-arm study, you can't actually tell whether they've done better than anybody else, because you need a control group to do that. So we would hope to do that in a future study. We wanted to see if they actually, using moxa helped them to complete their chemo according to schedule. We wanted to see if it might reduce their other chemotherapy-related toxicities, so the nausea, vomiting, fatigue, as I mentioned before. We wanted to take some measures of their quality of life, and we wanted to use a tool called the patient activation measure to see if you could use that as a screening tool. So if we were going to roll this out big time through the NHS, how would you identify patients who would be more likely to do this? So lots of questionnaires, and they're all lined up along here. And this is, I just mentioned this is a table of all those things that we're trying to measure, and these are explained in the protocol, which is in here. So we designed this as a single-arm uncontrolled feasibility study, and I've underlined feasibility study. We're just seeing what's happening. We're putting a stake in the ground, and we're measuring to see what's happening. It's a single site. We're using patients at Mount Vernon Cancer Centre, and we aimed to recruit 25 participants, and we were using mixed methods. So with the quantitative data, which is all the stuff I've explained, and then we wanted some qualitative data. We wanted to gather patients and healthcare professionals. So we had some focus groups and interviews and some written feedback from these people. And we have you have to set out your inclusion and exclusion criteria. And so basically we were looking for breast and gynecological and colorectal cancer patients who were prescribed radical or adjuvant chemotherapy in the early disease setting or first or second line chemo in the metastatic setting, and who were about to commence a course of chemo for which GCSF was not indicated. So Friedrich Stabler in his work says that if they're having GCSF is given to stimulate the white blood cell counts. So he suggests that there are problems if you put Moxa on top of that because you'll get overstimulation. You might get overstimulation of white blood cell counts, so that's why that's important. They needed to have a good life expectancy and able to understand the procedures, so in terms of language and cognitive ability. And the intervention, well, up to 10 days prior to their first chemotherapy cycle, they met with Claire, the health improvement practitioner, and she explained and demonstrated Moxa, and if they were willing to take part, she obtained consent and administered the baseline questionnaires. She taught them the procedure, how to find the point and how to deal with Moxa. And then she gave them a little Moxa package and some support materials and made an appointment for them to come back a week later. And a week later, she would check that the patient could actually handle and use the Moxa safely and correctly, address any concerns and questions that they had, and then they were given a full pack of Moxa supplies. And I will tell you what that comprised. We simplified, we changed, and this was done in consultation with Friedrich, who's an advisor on our study. So like it was Moxa daily, but it was 3 minutes on bilateral stomach 36. And we were trying to commence 7 to 10 days as he did and continue daily as he did, but our protocol was less than 10 minutes a day. And you can see the comparison here, his 6 points as opposed to our 2, his 5 minutes per point, our 3 minutes per point. His Friedrich's is 30 minutes in total, and ours is 10 minutes in total. And we aimed to carry out the rest of the protocol as he did. His requires a carer, but ours could be done independently. And whereas his protocol required the template, we taught the patient to locate the point themselves. So in setting up and designing this, there were lots of major questions to answer, and the 2 big ones are around the Moxa. Okay, what kind of Moxa should we use? Okay, what was the best Moxa? But also, what would be most practical and usable for this population? So I wanted something that minimized odor because chemotherapy patients are notoriously sensitive to smells. And I wanted to minimize smoke, partly because of the smell issue, but also because smoke sets off fire alarms and smoke alarms. And so we wanted this to be safe for home use and not give them problems with their alarm systems. And we also needed to be able to demonstrate it in the hospital. Now, we did have one room that had an extractor so we could use smoky Moxa, but that wasn't always available for when Claire was seeing the patients. So we needed to be able to use this anywhere in the hospital to demonstrate. So that meant smokeless Moxa. And I also wanted, and if you are a user of smokeless Moxa, you will know that the usual sticks are notoriously challenging to light. And so I didn't want the patients to have difficulty lighting. So we settled on this fine pencil Moxa, which you may be familiar with, okay? So this is much, as you can see, it's much thinner than the usual Moxa that we might be familiar with. So there are issues with those decisions, but you need to make a decision and just have your rationale for that. So, dose. Is 3 minutes enough? How much should you do? Okay, so I was concerned that, one, it should be easy and quick to apply, because these patients are low on energy by definition, so you don't want to set up something that's too difficult. I was very concerned. I said I'm a prodigious user of Moxa on myself. I managed to burn myself a lot, okay? And I know how to use this stuff. So I was very concerned that these patients might be prone to burning, particularly because the skin gets very delicate during chemotherapy. And a lot of them had comorbidities, diabetes and things like that. So the sensitivity is not so good in the leg. So we wanted to just hope that we would get an adequate dose without causing any skin damage. So that was why we chose the 3 minutes of smokeless Moxa. This is our kit, okay? So they got everything they needed. Is this going to work here? Can you see the little dot anywhere? It sometimes appears. Well, they've got the Moxa, and they've got a timer, they have these specially designed holders to extinguish that skin Moxa. They've got a lighter, they've got a little book to information to walk you through the process, and they've got their diary. And they also got a little memory stick. Oh, yes, there's more. They've got a memory stick with our video, the video, and on it, all about So that should be really easy, yeah? We put it in a little bag that you can see there, and they just have to assemble it and get it out every day and use their Moxa. What could be easier? Okay? So I was very concerned that as these patients were coming to Moxa cold, about really supporting them. So I wanted to have a lot of support materials for them. So a participant information sheet really lays out what the study, it's about this research study, and it's a requirement for research by the Department of Health. You need to have one of those, and it importantly has the complaints procedure if you have any complaints about the way the research is being conducted. Many patients like to find out what the evidence is, so we gave them a summary of the research evidence that we had according to our protocol. And then we gave them the detailed instruction leaflet, and there's a copy of it here. We worked with the information design team in the Linda Jackson Macmillan Center to produce this. And the important thing is that it's got a nice, usable design, and it's in patient-friendly language. And that was highly commended in the British Medical Association Patient Information Awards last year. So that is a quite nice accolade, and it brings Moxa to the attention of the mainstream medicine. We also produced a video and showing how to use Moxa, and so you can access that. That's on the Linda Jackson Macmillan website at that address. It is set in the context of the research, but you may find sections of it helpful. I'd also like to thank Peter Dedman, who not only gave his permission for using the diagram for the location of stomach 36 from the book Manual of Acupuncture, but he actually edited it to make it more patient-friendly and gave us that for the information leaflet. So thank you, Peter. So that was how we set things up. So what happened next? What do you think happened? Everybody did it every day, right? And they got a good outcome. Okay, so, the first issue is, can you recruit these patients? Well, it took us a while to recruit them, okay? And this is typical, with studies. Recruitment's very difficult, it's challenging. For us, it was quite difficult because Claire needed to take a leave of absence for 6 months, and so recruitment ground to a halt. So it's quite extended here. But by the end of 20 months, we had our 25 participants, and we had just about 3/4 were female, and 1/4 were male. And so that's quite good. We were glad to have the men coming in on the act. There were about 57 years of age on average, but that range was from 21 to 74. So we had some young people and we had some older people. The ethnic background is interesting because usually when I do studies, about 98% of the participants are white British. And so we had just about a 50-50 mix, so a very good ethnic mix, which is what studies like to see. And only one of those people had previous experience of using moxibustion. He was someone who'd been on our lymphedema study previously with a different cancer. Poor man. So looking at these cancer diagnoses, there it is, okay. So we had 13 colorectal, of our 25 patients, 13 were colorectal cancer patients, and we had a nice 7 men and 6 women. 10 were gynae patients, 2 were breast patients. And this is interesting to me, 3 of those patients who came on, this was their second cancer. So they'd been through this all before with a different type of cancer. And so you can see here that little pie chart. And this is just to show you the vast diversity in the chemotherapy regimens that they had. So that you can, and I'm not going to go through these, but really almost the breast cancer patients both had the same regimen, but there was a great variety amongst the other patients. And the planned cycles ranged from 3 cycles to 18 cycles. So some were on a short course of chemo, some were on a very long course of chemo. So our main outcome measure, the thing we were trying to see if people would be concordant with this, would they do it every day? And the way we collected this data was we gave them a daily moxa diary. And we tried to keep this as simple as possible. We just wanted them to put the date in the box, to say yes or no to whether they'd used moxa. And if they hadn't used moxa, we wanted them to tell us why they hadn't used moxa. And we really were trying to stress that it wasn't something they needed to lie about. We just wanted to monitor things, and we were happy if they missed. We just wanted to know why they missed, so we could collect that data. So that should have been easy. But, okay, so we got full baseline data for all 25 of our patients, but our daily moxa diaries, so 1/3 of our sample didn't return any of them, okay? And Claire she was quite persistent in trying to get them, but you do have to be sensitive. These people are often very unwell, okay? And she had one patient who said, oh, yes, we're doing it every day, but they never returned any of the diaries, so, that doesn't count, okay? We do have some data for 2/3 of our sample, for 17 of them, and only 3 of those people gave us complete data, okay? And then for the other, we've got a lot of missing data. Some they missed as little as 0.6%, but some 70% of the data was missing, okay, so not great. But the great thing is that we have 1,975 recorded applications of moxa, okay, so this is down on paper. We've got some good data to work with, and that's important when we talk about the safety. How are we doing here? Okay. So these patients, we aimed to recruit them 7 to 10 days before chemo starts, but actually what happened, the way our system is set up at Mount Vernon, that didn't work. Often we didn't meet them until the day their chemo started. So we amended the protocol and said we can recruit anyone up to the end of their first dose of chemotherapy, so up to 3 weeks in. So when you look at that, we had 44% who started 1 to 20 days before they started their chemo, 24% started on the first day of chemo, and 32% started after the start of their chemo. And the number of days using moxa ranged from 2 to 205. So one person did 205 applications of moxa. I take my hat off to them. That was good. But in general, okay, so we analyzed the 17 sets of diaries that we had, and there were 3 options. As I said, they checked whether moxa was used or moxa was not used, or there was data missing. And we found that no one was 100% concordant with the protocol. Nobody did it every day of the amount of time that they did, okay? And what did we find? That 3 of those people did it more than 80% of the time that they could have done it, and 8 of those people did it between more than 50% of the time, but less than 80%, and then 6 did it less than 50% of the time. So not very good compliance, okay? So this was truly disappointing to me, but really not surprising, because you are dealing with people who have lots of issues, okay? And as I said before, 8 patients didn't give us any data. So we were interested in why people weren't doing this, you know? You give a person a moxa stick, you want to see what happens, okay? Mostly they forgot, okay? Has anyone ever tried to do a daily practice apart from maybe brushing your teeth? Do you know how challenging that is? As a well person, how challenging that is. So if you're really unwell, it is super challenging, okay? Often they were too tired. There were a lot of medically related reasons. Days when the chemo was administered, they spent long days at the hospital, so they wouldn't do it. Many were on transport, which gives them incredibly long days. Days if they had other medical interventions, where they wouldn't do it. Hospital admissions, obviously. We had one patient who did have neutropenic sepsis. We did get a call from I think there were 2 people in hospital. We certainly got a call from one saying, "Can I do this in the hospital? Can I do this moxa in the hospital?" And we had to say, no, please don't do it in the hospital. That's not a good idea. And for a lot of them, chemotherapy side effects. So they were either too fatigued, or they were vomiting too much, or they were in some kind of pain. Many gave themselves days off, and it was very common for them not to do the moxa for the week after the chemo was administered, just because they felt so low. Often there were social reasons, if they were visiting or on holiday. Bereavement would be a reason why they wouldn't do it. Some were moxa related, the aversion to the smell, and we had some problems with the moxa, which I'll talk about. And there were some miscellaneous. One was just fed up. We don't know if she was fed up with the moxa or just life. One was the weather. I'll tell you about her if I've got time. And someone was out celebrating. Hey, that's a good reason for not doing your moxa, isn't it? This, I think, is the most important finding in this little feasibility study, is about the safety, okay? So we've got 1,975 recorded applications of moxa, but we know that people did more, so we reckon we've certainly got more than 2,000 applications of moxa by 25 people, and there were no reports of burns, okay? So I think that's really positive, because when I set up this study, I thought I'm going to have a lot of sleepless nights worrying about this, because people are going to burn themselves. I burn myself, so what's going to stop them from burning themselves? And so we looked at the qualitative data, and we found 3 reports where people had skin sensitivity. So one said, once I had the moxa stick too near my leg, but it wasn't like a 3rd-degree burn or anything. It was just uncomfortable for a time. And another one said he got the occasional smell of singed hair. This was a man, not being overly careful, never burnt my skin, just singed the hair. And another one said, apart from a couple of times when it went a bit too close to the skin, I found it easy. So this is very, very positive. So looking at how acceptable this was to patients, okay, so we did the focus groups and interviews and the written feedback, and there were mixed opinions about this. Many found it very helpful. They said it helped with their energy levels, and they noticed on the days that they didn't do it, their energy levels would go down, and if they did it again, the energy levels would go up. Many found it an important tool for empowerment. They felt empowered by doing this, and some felt it was a good way to take time out for themselves. Others found it difficult to gauge benefit, and the challenges were getting people to remember, establishing and keeping a routine, and gauging the heat. But most were pleased to have taken part in the study. Now, before the study, we checked how acceptable this was to healthcare professionals, and we had a range of responses. But they were surprisingly positive, because they said, we want something to give our patients. You know, we have patients who ask if they can do something. So if this is something we can give them, that's a very good thing. 2 of the oncologists were active supporters of the study, and it's no point, you don't get any points for guessing. It was the colorectal and the gynae oncologists. 2 oncologists wanted their patients to have access, but we couldn't managed that. One was outside of our catchment area, and it would have just given us so much more paperwork. And one had insufficient resources. He could send us the patients, but there was no one to collect the blood data for us because their team was too busy. But we did have some, so that was very positive, but we did have some very negative responses. And very early in our work to set this up, someone did say that, who could have had a lot of influence, said that doing anything with a fringe therapy like this would be damaging to the reputation of Mount Vernon Cancer Centre. And then the bottom quote comes from an oncologist who, when I took my little roadshow out around the hospital, he said, yeah, I'll give you 25 patients easily, no problem. And a year later, I was still waiting for a patient from him. And then he wrote to me and he said, I struggle to believe that it will have any effect on blood counts and would find it hard to recommend it to patients. Okay? And I think that's fair dues, and that's what the next challenge is, to get the data that would change his mind. After the study, we reviewed the healthcare professionals. Mostly they were positive. They felt there was more evidence needed about the benefits. They felt it was valuable for some but not all patients. But as they said at the beginning, it was a non-invasive way to give patients control and ownership. And no presentation on complementary medicine is complete without the P word. Here it is. They felt it was placebo rather than scientific benefit. So, I have a few minutes left just to talk about some of the findings. Okay, having funding opens doors. So I'm really grateful to the BACC for the money to set up this. As I said before, it opened doors. And the BACC is an NIHR partner. This is the National Institute of Health Research, and this is who you want to be with if you're doing research, particularly in the NHS. Recruitment to an NIHR partnered study contributes to the trust research figures. And this was something, there was a meeting that was really the final one of whether we went ahead of this. The head of that meeting, the chair of that meeting, was very anti-complementary medicine, but saying that this was an NIHR-sponsored study, swung that decision and let us carry out this study. Doing a demo, don't talk about Moxa, do a demo. And here I am with one of the chief executives of the trust, showing him the Moxa, giving him a Moxa study. And this was very powerful. This is more powerful than words. One of the consultants, I gave her a treatment. And so, they all start off very skeptical and they don't know what's going to happen to them. And while I was doing the Moxa, her phone went off in her bag. She's a very, very busy woman. She went to each and she said, no, I'll just leave it, So that was good. We had a lot of challenges with the Moxa, as I mentioned, the smell. We had a lot of broken sticks on delivery. Our first delivery of Moxa went astray, and we think that it probably was delivered to a football ground who thought it was football because the Moxa that delivered was just broken into tiny little pieces. And so we don't know, if that was the mail system, where that went to and who did that, how they broke. But we did ask our supplier to put more cushioning on their packaging so that it didn't break. This picture was taken by one of the patients, and you can see there's a crack there, so that's not very safe. So that happened with some of them. And we had the mysterious case of the Moxa that wouldn't light. So we had a couple of patients reporting that they had full boxes of Moxa that they could not get to light. And thank you. Yeah. And so when I reported that back to the supplier, and they said, oh, that's the patients, they don't know how to light. Well, these patients did know because we had previous success of lighting it. And then when I was in Rottenburg this year, I spoke to the other branch of our supplier, and they said, yeah, we get reports of that sometimes. Don't know why it happens. So if anyone's ever come across that, I'd be interested to hear more of that, okay? We need to know, we've discovered some new cautions that we hadn't covered in our literature. Please don't use it in a hospital ward, and please, please don't use it if you're on oxygen, yeah, okay? And we have these outstanding questions about dose, as I've said before. Challenges to the patients. Well, this is an intervention that's offered at a critical time when they're anxious and they're already taking in too much information about their chemo. We were very surprised by what poor health many of these patients experienced. Prior to participation, they have complex chronic conditions. They're not just suffering from cancer, they have other issues as well. There were acute conditions, their current cancer, their previous cancers, and some of this poor health increased during chemotherapy, and there were some poor outcomes inevitable. So a couple of patients died, but not while they were on the study, and it had nothing to do with the moxa. Chemo fog, okay, notorious chemo fog. That's probably why they can't remember, because they're not thinking clearly. Chemotherapy-related fatigue is a problem, and the daily routine is a challenge to anyone. And I'm just going to go to the conclusion. So this was a feasibility study about learning what is possible. We believe it's the first attempt to introduce moxa to a chemo setting in the West, certainly for self-administered. But it seems that the protocol can be taught to chemo patients who aren't acupuncture patients. It appears safe, and we had an overall positive report from the oncology health professionals, but there are challenges. And moving forward, well, there's two questions. If we had better data, we would be able to tell these patients what benefits there are more clearly, and we might get better concordance, but we can't get better concordance until we need the better concordance to get the better data. So we're in a bit of a catch-22 situation. And the other thing is, where do we go for funding for further research? I will leave you with the quotes of two of the patients there who were very positive. One said, participating in this study enabled me to have a part in managing possible side effects of chemo. I kept really well throughout my treatment, so I'm pleased I participated. And another who said, I would suggest to use moxa for people who quickly get tired, people who feel the collapse of power. Moxa helps, and people can at least do something. I thank you kindly for your attention. We might have a couple of minutes for some questions if you have any, or comments. Thank you.